I would like to show you today presentation about brackets positioning. First of all, I would like you understand that a proper finish begins with a proper start, and stage of orthodontic treatment like bracket placement, it is a very important stage. Perhaps the single most important phase of orthodontic treatment is proper bracket placement. Taking time to achieve proper placement at the outset can help mitigate or even eliminate final archwire bends and correction. And of course, save your time, save your nerves, and save your money. So, what does it mean, bracket position? Bracket position is extremely important, as otherwise the teeth will not be correctly aligned. Modern brackets are based on the straight wire technique. This means the brackets have the torque tip instead of set built into the bracket, which reduces the need for bending edge wires at the chair side. However, it means each tooth requires an individual bracket correctly placed on the buccal surface, or in a lingual surface in case of lingual brackets using. The brackets are positioned on the tooth at the facial axis, FA point, with the plane of the edge wire slot placed at a specific angle relative to the facial axis of the clinical crowns, FACC, abbreviation, facial axis of the clinical crowns. And now let's talk about terminology. What does it mean, facial axis of the clinical crown? The most prominent portion of the central lobe of each crown's facial surface is called facial axis of the clinical crown. For molars, the buccal groove that separates the two vestibular cusps. Next notion, Andrews plane. The surface or plane on which the mid-transverse plane of every crown in an arc will fall when the teeth are optimally positioned, called Andrews plane. This plane virtually connects the appliance through the FA point. The point. What does it mean? Facial axis point or FA point. The point of the facial axis that separates the gingival half of the clinical crown from the occlusal half. And now I would like to show you upper arc facial axis points in the upper picture. And upper arc brackets on Andrews plane line. As can you see, slots of all brackets and molar tubes are on one plane, Andrews plane line. And the same picture for lower dental arc. In the upper picture, they are shown lower arc facial axis point and lower arc brackets on Andrews plane line. To cite the bracket to ensure its correct placement, it is important to view the bracket correctly. What does it mean? It means that our eye must be under right angle to the tooth surface, not under another angle, only under straight angle. This means viewing the bracket directly, as illustrated in the above diagrams. A mirror may be used to view the upper brackets and teeth from the occlusal surface. But please, doctors, nota bene, the accurately placed brackets will give better control on three-dimensional position of the teeth during treatment. An accurately placed bracket will also result in better expression of its built in prescription, and orthodontists will need less wire bending and complex mechanics during the course of treatment. Now let's talk about mesiodistal position of brackets. It is a general saying in orthodontics that brackets should be placed at mesiodistal center of the teeth. This statement is partially correct, but only partially, as this rule can be applied to all the teeth, to all group of teeth. What does it mean? Please, nota bene. If the bracket is not positioned properly mesiodistally, unwanted rotation of the tooth occurs. A more clear description for right mesiodistal position of brackets was given by Andrews, that brackets should ideally be placed at the mid-developmental ridge of the teeth. They are shown mid-developmental ridge in the upper and in the lower teeth. And let's talk now about positioning of brackets on different groups of teeth. First group of teeth, maxillary and mandibular incisors. Bracket should ideally be placed at vertical lines showing mesiodistal center of the upper and lower incisors. Brackets should be placed at the recommended height on this line. Next group of the teeth, canines, maxillary and mandibular canines. Placing brackets at the mesiodistal center of the canines will result in contact point error and slight rotation of the teeth. At the mid-developmental ridge of upper and lower canines lies slightly mesially to the mesiodistal center of the teeth, and is more mesial in case of lower canines. not in a half width of tooth, but a little bit mesially. And in the lower canines, more mesial than in the upper ones. Bracket is placed slightly off center and toward mesial in case of canines, as can you see on this picture. Bracket placed more mesially from center of the tooth and more orally. The vertical lines on maxillary and mandibular canines indicate the mid-developmental reach of the canines, and ideally, the middle of the bracket should coincide with this line. Next group of teeth, mandibular premolars. Roth purposed that premolars brackets should be placed at the area of maximum convexity, which is usually the mesiodistal center of the teeth, and mid-developmental reach also lies in this area, like on this picture. But look at these pictures and look at mandibular premolars. Brackets must be placed like here. Sometimes the area of maximum convexity lies slightly mesial to the mesiodistal center, but degree of mesial deviation is less than that of canines. The difference between bracket placement on premolars and anterior teeth is presence of a lingual cusp on premolars, which must be taken into consideration while placing the brackets. Maximum convexity lies slightly mesial to the mesiodistal center. The cusp of the patient should be examined to detect position of the maximum convexity. As can you see, they are shown slightly mesial position brackets from mesial slope in lower premolars. But in this case, we can see also more mesial position than central point of a lower premolar. In mandibular premolars, the buccal and lingual cusps lies at the same level in the mesiodistal perspective. So, when placed in lower premolar brackets, the scribe line of the bracket should coincide with line connecting the buccal and lingual cusps. A left lower second premolar bracket bonded so that the line connecting the buccal and lingual cusps passes through the scribe line of the bracket, like here. This is because buccal and lingual cusps of the lower premolars should be present at the same level in mesiodistal perspective. But what about next group of teeth, maxillary premolars? In maxillary premolars, brackets should be placed so that the scribe line of the bracket is slightly mesial of up to half millimeter to the line connecting the buccal and lingual cusps. A red line. It is line connecting buccal and lingual cusps. But yellow line, it is medium line of bracket. As can we see, these two lines are not coincide. Bracket placement on maxillary premolars is different from mandibular premolars, as maxillary premolars should have slightly rotated position at the end of the treatment, while the lingual cusps have cusp-fossa relationship with lower premolars in class 1 and 2 molar occlusion. Maxillary premolars should have slightly rotated position at the end of the treatment. According to Andrews' sixth case of normal occlusion, the buccal cusps of upper premolars should have a cusp embrasure relationship with lower premolars. And opposite side. According to Andrews' sixth case of normal occlusion, the buccal cusps of upper premolars should have a cusp embrasure relationship with lower ones. So, if the buccal and lingual cusps are in one line in the mesiodistal perspective, then both buccal and lingual cusps will have a cusp embrasure relationship with lower dentition. Such a relation is not acceptable. Please pay attention. Cusp of upper premolars are not fully at the embrasure, but a little bit at the surface of lower antagonists. According to Andrews, the buccal cusps of upper premolars should be slightly more distal than the lingual cusps in the mesiodistal perspective. And in that case, intraorally, they are shown intraoral view. Palatal cusps of the upper premolars will take place in the grooves of lower premolars, and this kind of position of the teeth will be correct. So, once again, in maxillary premolars, brackets should be placed so that the scribe line of the bracket is slightly mesial of up to half millimeter to the line, red line, connecting the buccal and lingual cusps. Keeping the buccal and lingual cusps of maxillary premolars in the same mesiodistal perspective will cause poor occlusal results. A bracket bonded slightly mesial to the line connecting the buccal and lingual cusp of maxillary second premolar. Bonding the bracket in this position will rotate the buccal cusp distally and lingual cusp slightly mesial to get ideal relationship in a class 1 molar relationship. I would like you to understand it. The bonding the bracket in this position will rotate the buccal cusps distally and lingual cusp slightly mesial to get ideal relationship in a class 1 molar relationship. But for class 3 molar finished cases, though there are no guidelines available in the literature, but many authors' opinions is that upper premolar should be bonded like class 1 cases in surgical and orthopedic treatment. But if the orthodontist is aiming class 3 camouflage, then upper premolar brackets should be bonded slightly distal to the mid-developmental ridge so that the buccal and lingual cusps have the same prominence in mesiodistal perspective. And we can see follow-up of treatment. Please pay attention to correlation between upper and lower canines in the 9th week of treatment and 14th week of treatment. Correlation between canines, incisors and premolars are improved. And we can observe initial situation, full third class, mesial shifting of lower dental row in one premolar. It is not half third class, it is full third class. But after 9 I told week 9 months of treatment, situation looks like this. Please notice that treatment includes orthodontic microimplants. 14 months correlation between canines and premolars is almost correct, but after 20 months of treatment with third class elastics, treatment almost finished with very good result. And next group of teeth, maxillary and mandibular molars. Conventionally, bands are placed on the molars. The most suitable band is one that snugly fits the tooth. Whether molar bands or tubes are used, the optimum mesiodistal position is decided by taking the mesiobuccal cusp as a reference. The mesial opening of the tube should be lie below the mesiobuccal cusp at the correct vertical height. Please notice that every mesial opening of every every molar tube here, here, or tubes welded to bands. Aligned below the mesiobuccal cusp. Bands placed on upper and lower molars. The mesial opening of the tube lies below the mesiobuccal cusp of the molars. The rule holds true for both first and second molars in both arches, upper and lower. Please pay big attention to checking mesiodistal position of the brackets. The mesiodistal position of the bracket can be checked under both direct and indirect vision. For indirect vision, diagnostic mirror is used. Generally mesiodistal position of upper incisors, premolars and molars brackets is checked under indirect vision. But very often we need to modify mesiodistal position of the bracket, depends on clinical situation in oral cavity of our patients. Alteration in mesiodistal position of the bracket will after the prescription of the bracket in terms of counter rotation. Some situations where mesiodistal position of the bracket is altered are given. Please look at this picture. Tooth number 15 is rotated because we must to fix bracket for this tooth slightly in not classic position. The same situation shown in this picture. And doctors, please notice that they are shown self-ligating brackets, my likely brackets. What about rotated teeth? In case of rotated teeth, the bracket should always be placed more on side of rotation in the mesiodistal plane. This overcorrected position of the bracket will result in early correction of the rotation and will also accommodate the relapse factor after debonding. They are shown a rotated maxillary second premolar. As the tooth is distopolatally rotated, so the bracket is placed slightly more distal than its required position. So doctors, if we would place this bracket classically, vertical slot of bracket must be here, but this tooth is rotated because we placed bracket a little bit distally. Next clinical note. Sometimes due to severe rotation or crowding, The position of the tooth is such that it's not possible to place bracket at the right mesiodistal center of the tooth. Clinical case. Patient has severe crowding of frontal teeth and tooth number 1 has position when we cannot put bracket classically, correctly. Correct mesiodistal position of the bracket is not possible on the first bonding visit due to rotation, due to severe rotation. The bracket should be placed as far mesial as possible. The mesial side of the bracket should not come in contact with left side incisor because it will hinder the full insertion of the wire and also make a ligature placement extremely difficult, is not impossible. In such situations, the bracket should be placed as far as possible toward the mesiodistal center of the tooth or toward the rotation. A flexible wire is passed and only the bracket's wings toward the rotation are ligated. At subsequent visit, the tooth is usually derotated enough to place bracket at the right mesiodistal position. So the bracket is debonded and either recycled or new bracket is rebonded at the correct mesiodistal position. But please, doctors, nota bene. Sometimes the tooth is rotated 180 degrees, so that the lingual side is on the labial side. Many times this form of rotation is accepted. In such situation, the bracket is bonded on the side of the tooth, which is facing labial or buccal. Clinical case. Tooth 4-1 is rotated 180 degrees. The rotation was accepted and bracket placed on lingual side of the tooth which was facing labially. But doctors, moreover, please pay attention. It is not only one anomaly. They have placed anomaly called dystrophy of teeth. Please pay attention. A lower right canine is placed between tooth number 4-1 and 4-2. Let's calculate the tooth number 4-1, 4-3, 4-2, 4-4, 4-5, 4-6, 4-7. Another situation is maxillolateral incisor substitution by canine. In this situation, the slightly convex labial surface of canine is made flat to give it shape of lateral incisor, and bracket is bonded at mesiodistal center of reshaped canine instead of slightly mesial. Do you remember, doctors, yeah? That classically we need place bracket slightly mesial, but in case of primary adentia of upper lateral incisors and in case of treatment this patient with mesializing of canines to the place of lateral incisors, we need position brackets more distally. Placing the bracket at the mid-developmental ridge area will cause poor contact point with the central incisor, as canines also reshaped mesiodistally. On premolar tooth, which will become future canine, the canine bracket is placed distal to the mesiodistal center of the tooth. Please, nota bene. The lateral incisor brackets were bonded to the canines, and the canine brackets were placed on the first premolars for patients with primary identity of upper second incisors. Before bonding the lateral incisor bracket on the canine, the labial surface was reshaped for the bracket adaptation. It is necessary to position this bracket gingivally to permit the recontouring of the canines required for aesthetic and function. The orthodontist should place the brackets according to gingival margin height rather than incisal edge or cusp tip. To make the canine appear less curved and more like a lateral incisor, the bracket was placed more distally in the center of the canine rather than at the height of contour. In addition, a canine bracket was placed on the first premolar in the same mesiodistal position, more distally, in which it is placed on the canine. The need for canines extrusion and premolar intrusion to adjust the gingival level. And regarding canines mechanics, special attention should be given to the torque that the canines should receive, namely lingual root torque. But, however, to improve the interproximal contact points, offset bends in-out was needed between the central incisor and canine. This bend is called offset bend or in-out bend. They are shown occlusal view of canine substitution. And then we need to do reshaping of canine and first premolar. We need reshape canine like lateral incisor and first premolar like canine. Post-orthodontic occlusion would show maxillary canines having substituted the lateral incisors, with the first premolars as canines. The maxillary canine, which would then substitute the maxillary lateral incisor, requires accordingly reshaping and composite work of the labial surface. Cusp tip, proximal surfaces and incisal edges of the canines for them to mimic lateral incisor during treatment. The maxillary first premolar, which would then substitute the maxillary canine, requiring reshaping the mesiobuccal slope and some reduction of the lingual cusp for functional contact with the distal slope of the mandibular canine. The lingual cusp of the maxillary canines and first premolars are recontoured to eliminate traumatic occlusion of the mandibular lateral incisors with the lingual surfaces of the canines, this place, and establish balanced occlusion. After the teeth have been aligned and the canines reshaped, there is frequently a need for restorative treatment to recreate ideal lateral incisor color and contour. This may be accomplished with bleaching, light cure composite, or a porcelain veneer. Please look here. After space closure, the unfortunate appearance of both canines. And traumatically injured right central incisor. And picture B, combination grinding of the canines and composite build up on the mesial aspect of the canines and the incisal edge of the central incisor. But, doctor, as can you see, this tooth is yellowish than central incisor. When you will discuss with your patients with primary identity of upper lateral incisors, this option, visualizing canines into place of lateral incisors, we need to remember that canines are yellowish, and you will need you will get to more work to bleach it, and this procedure is not always successful. Placing the bracket distally will rotate the tooth mesiopalatally, which increases the mesiodistal width of future canine tooth, bringing the convex part of the tooth mesial so that it looks similar to the mid-developmental ridge of canine. As can you see, the first premolar has a roll of canine. This position of bracket also helps to hide the palatal cusp of premolar and improves the occlusal relation with the mandibular canine. The palatal cusp needs to be grounded to avoid premature contact with opposing dentition. Let's talk about axial or long axis position of the brackets. Axial or long axis position of the bracket is related to the angulation or tip of the teeth. In conventional edgewise system, where there was no built-in tip, the brackets were placed angulated on the tooth, like on this scheme. The amount of bracket angulation on the tooth was equal to the amount of tip requires. Standard edgewise brackets has no built-in tip, and bracket position didn't follow long axis. Blue line, it is long axis, but long axis of bracket is not coincide with long axis of tooth. Bracket position didn't follow long axis of the crown or root and were placed angular on the tooth equal to the amount of tip requires. In pre-adjusted edgewise system, as the tip is already built within the brackets, so placed in the brackets similar to standard edgewise, will result in increase or decrease of built-in tip. In pre-adjusted edgewise system, brackets are positioned on the tooth so that their wings and scribe line are parallel to long axis of clinical crowns or long axis of the tooth. A pre-adjusted bracket of maxillary left lateral incisor. Tooth number 2-2. Placing the bracket parallel to long axis of clinical crown will cause tooth to rotate in a clockwise direction and express the built-in tip. But there is always some difference between the angulation of long axis of the crown and long axis of the tooth in the mesiodistal plane. There is always some difference between long axis of clinical crown and long axis of the tooth. Also, placing bracket according to long axis of tooth may result in a wrong mesiodistal position of bracket on the crown. Andrew purposed that as the clinical crown is only visible in the mouth, so the angulation of the tooth should be taken by taking the angulation of the long axis of clinical crown, abbreviation LACC, and not the long axis of the entire tooth. But taking only the long axis of clinical crown may result in poor root parallelism, and in some cases root resorption due to roots approximation of adjacent tooth. A lateral incisor bracket placed with reference to long axis of clinical crown. X-ray showing that long axis of bracket not coinciding with long axis of the root, like here. And because of this, root of the lateral incisor is in close with contact with central incisor root, increasing chances of root resorption in this area. So brackets should ideally be placed by taking the clinical crown as a reference, but root position should also be kept in mind. If there are chances of adjacent root resorption by taking clinical crown as a reference, then bracket position should be modified and long axis of the tooth should be taken as a reference. Taking the long axis of tooth can result in poor proportions of connectors and embrasures. These proportions can be corrected at end of treatment either by composite buildup or interproximal reduction. Please pay attention. Scheme A. Golden proportion of connectors that ideally should be present in finished cases. And scheme B, a case with delacerated central incisor root. If there is root delacerations, placing bracket by following the clinical crown will result in ideal connector areas but greater chances of root approximation and so root resorption. At this scheme, we can see that bracket placed by following the long axis of the roots. The golden proportion of connectors is distorted. They can be resorted by composite build-up or interproximal stripping at the end of treatment. Next clinical notes. Some clinicians also take incisor edge as guideline for long axis positioning of brackets. But incisor edge is mostly uneven due to trauma, attrition, and mamelons. So incisor edge shouldn't be taken as a reference point for long axis position of the bracket. Also, gingival zenith top shouldn't be taken as a reference for long axis position for the bracket, as it can be affected by uneven pattern of gingival recession. Please look at picture A. Mamelons on central incisors. These mamelons will give a different long axis position of the tooth if taken as a reference for bracket position. Picture B. Attrition of the incisor. Attrition of the incisor edge will also affect long axis position of the teeth. Picture C. Gingival zeniths shifted mesial from their ideal position due to gingival recession. Taking gingival zeniths as a reference for actual position of the bracket in these cases will result in wrong placement of the bracket. Please keep in mind importance of actual position of brackets. Correct axial position of the bracket is very important for proper occlusal and aesthetic relationship. As pre-adjusted brackets have built-in tip, a poor axial position of the bracket will result in expression of increase or decrease positive or negative tip. Increase in tip may increase space requirement in the arc and also increase risk of adjusted root approximation. Scheme and B. Pre-adjusted brackets not placed in accordance with long axis of the tooth will result in increase or decrease expression of tip, the built-in tip. Picture C, panoramic X-ray. A X-ray showing that both decreases and increases tip of incisors due to angle of bracket placement. This increases chances of root approximation and root resorption. Pictures D and E. Over-angulated brackets placed on the central incisors can result poor proportion of connectors and embrasures, leading to development of black triangle. As can you see, at the finish of treatment, patient have got not so pleasant result called black triangle. Change in tooth angulation will also affect the golden proportions of connectors and embrasures, and so the smile aesthetics of the teeth. How can we check axial position of brackets? The axial position of the brackets is checked under both direct and indirect vision. Usually, maxillary anterior brackets and mandibular brackets are checked under direct vision from labial side of the tooth, while maxillary posterior brackets are checked under indirect vision using diagnostic mouth mirror. If there is doubt in position of maxillary anterior brackets, especially lateral incisor brackets, some clinicians favor to use indirect vision by diagnostic mirror and use guidance from a lingual side of tooth. But you need to know that there are present another modifications in axial position of brackets. Modifications are made in axial position in the following circumstances. First of all, to avoid chances of root resorption due to adjacent root approximation. To avoid root resorption from dental or orthodontic implants. Third, to avoid root resorption from teeth impacted in bones. Especially of impacted canines or mesiodents. Orthodontic implants inserted for intrusion of maxillary incisor. We can see on this panoramic X-ray. Note the position of lateral incisors are at both ends. The gingival veins of the brackets are facing distal, so they will rotate both lateral incisor roots toward mesial. Initially, such bracket placement will create space for implant insertion, and during intrusion, it will ensure that roots of lateral remain away from implants. Once the intrusion is completed and the implants are removed, bracket position is corrected so that lateral incisors have optimum angulation. Another situation. A mesiodens present between roots of the upper central incisors. Brackets placed so that veins of the brackets are facing mesial or gingival side. This will rotate both the central incisor root away from mesiodens and will give good access to surgeons for removing it without causing any damage to central incisor roots. And as a result of treatment, central incisors have got correct position. The bracket position needs to be corrected after mesiodens removal, otherwise black triangle will result in central incisors. Next modification to accommodate crown morphology for achieving golden proportions of connectors and embrasures. Fifth point. In some surgical cases, bracket position is modified to move roots away from surgical site. For example, in case of Westmont procedure in maxilla, also called anterior subapical or segmental osteotomy. And If teeth have slightly smaller size, such as peg laterals, then it is better to increase the angulation of the teeth rather than to go for composite build-ups. At the end of our lecture, I would like to advise you a few free articles about today's topic. If you would like, you can find it in internet and to get more information about it. First article, bracket position and resets. 5 steps to align crowns and roots consistently. And next article, a comparison of accuracy in bracket positioning between two techniques, localizing the center of the clinical crown and measuring the distance from the incisal edge. Accuracy of position. Third article, accuracy of positioning. 3 types of self-ligating brackets compared with the conventionally ligating brackets. Thank you for your kind attention. Goodbye. Have